Let me go ahead and get started. My name is Bert Houston. Do tamahin shlo kaya ani bashishchin na kaida na bashichay do tachiri dashmele. I'm originally from Kaibeto, Arizona, which is just east of Canada, but I do. My office is located in Gallup, and that's where I reside with my family, my spouse, and my children. Although sorry, I keep forgetting that I'm in the library. I work with a tribal opioid response program, and our program name is Center of Harmony and Recovery. And our office is physically located in Gallup, New Mexico, but we cover and travel to the Navajo Nation and cover the entire Navajo Nation. So, I'm Bert Houston. I'm a case manager with a tribal opioid response program under the Navajo Nation, and our office is located in Gallup, New Mexico. I am originally from Kaibeto, Arizona, which is east of Ganado, Arizona, but I currently live in Gallup, and then that's where I reside with my family as well. I'll let my co-presenter go ahead and introduce himself.
Hello. Good afternoon. I almost said good morning. I don't know what you know. Again, thank you for being here today. Is it pretty warm in the auditorium, or is it just me? Is it just me? Or is everybody like okay with the temperature in the auditorium? It's pretty warm in there. I tried standing in there, tried listening. I was like, man, this is too warm for me. So, my name is Delton Francis. Najini Bashichin Tabahadashi, Ado Tajikina Shanan, although lay that this and hot sad Shawan, Ado Shawan, Conde, Tona Hale, you see, I did not show. Does anybody know where that this and hot sad is? What? Page, good job. So I need to remember this person here. So thank you, Kobe. Let's give a round of applause for Kobe. He's an excellent worker. He is helping me get my stuff. He's always an awesome person to work with. And he's a planner with the Division of Behavioral Health. So So I think out of everybody from the DBMHS, I'm always like the furthest that travels a lot. So a lot of road miles. So again, my position with Navajo Nation Division of Behavioral Health is prevention specialist. I've been doing that for 3 years. But I would like to say, unofficially, I've been doing it for more than that. I helped run a facility. It was called Rainbow Bridge Treatment Facility in Page. And then I also work in an outpatient program out in Kaibeto. Same program, Division of Behavioral Mental Health Services. But at the same time, that was not my first stint in behavioral health. I started working in a detox facility in Page, Arizona. Back then, it was called Community Behavioral Health, and it was run by the state. I would like to say it's a non-native entity. I learned a lot of the basics in and outs of behavioral health, down to billing, down to case management, down to how to work with clients off the street. So I believe we have one person from the last workshop talking about how they work with clients one-on-one. And I couldn't really chime in that time because it wasn't my presentation at that time. But that's the experience I hold as far as the IOM model. Are you guys familiar with the IOM model? I think they're slowly changing the name. You guys know what the IOM model is? You guys should, right? You guys are all in the health field, right? Some of you? Who's in the health field? I'm not trying to embarrass you. Okay, so some of you are in the health field. Okay, so IOM is the Institute of Medicine model, right? Or I think it's called what's the new word? I know they're coming up with a new phrase from SAMHSA, but it's a spectrum of services, just like with clinic and hospitals. There's prevention, outreach, prevention, inpatient, outpatient, aftercare. Does that sound familiar? Okay, so all hospitals operate within that model. And today we're going to be discussing opioids. And my colleague and myself, Bert, has entered this field not too long ago, so she's still kind of a newbie in this field. For me, I'm going to say 10 plus years. Because I was doing detox work at the same time, I was also working with Page Unified School District as a mentoring coordinator. So what I would do is I would also work with at-risk youth, bring them in, talk to them, and then set them up with mentors. So during that time, I had to figure a way for the straight A student to connect with the student that's having a hard time in school, that might begin to start experimenting with drugs and alcohol, maybe a student showing up drunk, maybe a student showing up high. So those were the students I was working with. And also same thing in detox when I was working with adults that were coming in off the street. So these were individuals that were coming off the street, hitting rock bottom, coming in through the door, calling me every name in the book, and I had to learn how not to take it personal. How many of us cannot take anything personal? Is it easy? It's not, right? When someone comes right at you, start talking to you, telling you every name in the book, cuss word. So when I applied for that job, and one of my first supervisors, he told me, and just kind of echoing what my grandpa told me when I told him I was working in this field. My grandpa told me, because he was a medicine person, and he told me when I used to help him out, he goes, "The never catch you, the asahal na vara, the asahal sazina, the kehno, the bahano, the jahano." So in reminding that, you have to look at an individual as a person, as a whole person, not just a patient. Is what he told me. So just like you, they have a lifestyle, they have theories, they have family philosophies, and that's what they're coming with. So when he said, when you start working with people, just take it in that manner. Look at that person in that way. Look at the whole person. Don't just look at what's wrong with them. Don't look at the defaults and defects. So same thing, my new supervisor, and we'll get into the opioids. I just want to tell you a little bit story of my background in behavioral health. So at this time, he told me, and I think it'll be general for everybody to see what I'm talking about in my story. So he told me, and my new supervisor, he was an elderly person too, and he told me the same thing. He said, when this job is going to be difficult, and back when I was starting in my late 20s, he's like, this job is going to be difficult. You're going to have to learn how to have thick skin, he said. And I was like, what do you mean by that? He goes, have you seen somebody that's been inebriated, that's been drunk? I said, yeah, I have family members that have substance abuse issues. He goes, I'm glad you know that word. I was like, yeah, I do. He goes, well, what happens when they're using? I said, they say all these crazy things. He goes, that's it. When people are coming in off the street, you're going to have to understand they're going to come at you like that. But don't take it personal. You have to look at that person again as somebody's daughter, somebody's son, somebody's father, somebody's aunt, somebody's grandma, somebody's grandpa. Is what he said. So I was like, yes, I understand that. Kind of echoing that from my grandparents. So that's how I started my work, and I got into the field, and I would get comments, I would get all these different cuss words said to me, and one of the stories I had was that this one grandma lady came in, she had her traditional clothes on, she had her cliche on. Oh man, she was pretty inebriated. And she was saying everything bad in Navajo to me. And I was like, oh my God. This was my first time dealing with an elderly woman that was drunk. So, and she said everything in Navajo that was real bad and negative. And I was doing a night shift. Called being down, in the morning when she woke up, total Jekyll and Hyde. Okay? Total Jekyll and Hyde. And first thing she says to me was, ya te pineshi ya. She goes, and I was like, oh my God, it's totally different than what she was calling me last night. So I said, oh, ya te benebedishno. And she goes, total Jekyll and Hyde. So sometimes when they're inebriated, that's not who they are. Okay? The real person is probably different. That's my point. And the second story was this older person, this elderly man, came through, he kept coming through, and my job was to try and refer him and try to get him to AA, trying to get him into some type of services. And they would tell me the truth. These people would tell me the truth of what's going on. And he kept coming through the door, he kept coming through the door. Why do you keep coming through the door? Why do you keep using? And then he goes, well, I get paid on the first, my family brings me to town, they take all my money and they take off. And that's what he would tell me. And then I was like, all right, so maybe there's a different way. There's a different way of approaching your finances, a different way of handling your money. Like that pattern of behavior needs to change. And he goes, yeah, no, big actually didn't. He goes, like, he's getting grumpy, he's hanging, he has a hangover. He's like, don't tell me about this stuff. He's saying in Navajo, don't talk to me. I'm an elderly person, he goes. I'm an elderly person. You have no say-so, he goes to me. He says to me in Navajo, he goes, he goes, often, no? And he's all like, this doesn't match what's going on right now. This is awkward. A young person telling me how to live my life. He goes, I'm the older person. I'm supposed to tell you how to live your life, he says to me. He said that to me. So I'm sitting there and I'm thinking, okay. I said, yes, you're correct. He goes, well, he used the word chamain. He goes, chamain, you don't know anything, And he goes, you're a young person, you don't know anything. And I said, yes, that's true, but I want that knowledge. What you did in life. What you can tell me about it. What did you do for life? What did you make money for? How many grandkids do you have? Relationships. What is that for you? And he goes, nobody really asked me that. People just always thought they knew what I was doing, and I would drink and they would just leave me alone. So through those lens and that perspective of working with individuals, I've come across all types of people. I've come across all different nationalities with substance use. I've seen people on meth. I've seen people on opioids. I've seen people on cocaine. So I've been exposed to those individuals one-on-one with proper training and proper way of taking care of them. So that was my previous job. And I slowly got into behavioral health when somebody knocked at my door and recruited me from DBHS. They're like, I heard you do good with clients here. Come over to DBHS. Let's do treatment. I think you'll like doing treatment and working with individuals. So in that process, I went ahead and went from talking to individuals at rock bottom all the way into treatment. And that's where I started learning a lot more about behavioral health. That's where I started learning about the IOM model. And that's where I started learning about the different services available. So right now I'm coming full circle. Now I think the best of what I want to do is in prevention. I've done the rock bottom, people coming in from the street. I've done inpatient work. I've worked with groups. I've worked with individuals coming through treatment. That whole case management process, reuniting people with their families, talking about issues that are tough at home, talking about stuff that they don't want to talk about. And then now I feel like I fit in prevention. Okay? So that's where I come in, and working in this field, I got to know my colleague here, Bert Houston. Again, she's very new to the program. I know 2 years, about 2 years? 2 years, she's barely in the behavioral health field. And during that time, we went out and we talked about opioids, we did presentations, and we just kind of started working together. So when we're out together, we do real well in the community. Believe it or not, I was there for her first presentation. She came out to Kaibeto school as a Christian, because I believe that this opioid is very dangerous. I went to a conference 3 years before this was an issue. I came back from Phoenix and I kept telling my higher-ups, we need to do something about opioids. We need to do something about opioids. We need to do something about opioids. Until now, when it's starting to take more lives, crime rates are up, then it's like, hey, let's do something. And that's usually how it goes, right? With trends of drugs and alcohol. So we don't have the clicker, right? So, we'll go ahead and get started. So that's just my backstory, behavioral health, and I believe it goes generally across the message. of what you guys are working with. Some of you are in the health field, and some of you are in education. I'm going to assume education. Anybody in education? Schools? What do we have here? I know you guys raise your hands for health. What do we have here? Is there anything else? Behavioral health? Public health. Okay. So that's still the health field. Okay. Awesome. So everybody's kind of like in the health field, right? So these stories is just kind of generalizing how I see working with people. And I tell people that I'm very honest with even my use too. Like even my use as a young person, I've experimented with alcohol, mainly just alcohol, not too much into the drugs. I really stayed away from it because it freaked me out, to be honest. But I haven't used alcohol for a very long time. I have taken patients and clients to AA meetings and just sit there and listen. A couple times I went on my own just to be there, and there's a lot of support there, and it's free. And so objectives for today is we're talking about opioids, and learn how opioids work in the brain, ways you can safely store opioid medication, how to safely dispose of opioid medication, alternatives to non-opioid pain management, risk and protective factors of opioid use, and reflection and finding balance. And before I go any further, is everybody okay with me going forward in English, or do you guys want me to translate some to Nick Etchers? I'm sorry? Oh, okay. All right. So I'll go back and forth. You guys okay with that? We usually do that, so we kind of do that in tandem. So the Nick Etchers the opioids is any. So go ahead. Our clicker doesn't want to work this morning. So how do opioids work? It says the opioids in a drug attaches to receptors in your body, and receptors receive fewer pain messages. The user feels good. Opioids can trick your brain into caring that pain is there. When the substance is used, the brain floods with large amounts of dopamine. So who has used, anybody in here, who has used opioids? I have.
For pain medication.
Yeah.
For pain medication, yeah. Not illegally. Like illegally, you're all like, no, I'm just kidding. And again, when I do presentations, anywhere I go, this is judgment-free zone. You guys are safe. I have no judgment on anybody. We go what we go through, and we go day by day. So, opioid, yeah, I've had some surgeries in the past, and when I was on opioids, I did not like how it made me feel. It made me feel too wonky. When I was out of surgery, my son's like, "Dad, what's wrong with you?" So like, it makes you feel funny, right? For some of you have used it for pain management, and you just feel a disconnect, right? At least that's how I felt. And luckily, there's a way where a lot of people want to use it to cope with, emotional stress, life trauma. And can I get some volunteers? Because I want this to be the best workshop that you guys experience. So I want some volunteers.
You're not going to be jumping or...
No, you're not going to be jumping or anything. You're going to be standing still. We got one volunteer, we got two, and we got three. Cool, on the back row. That's where I used to kick back in school too.
The naughty ones.
We won't get anyone if you throw it.
All right, so you three come up, maybe one more person? Okay, cool. No, we'll do. So we're gonna we'll put you here in the middle. No, actually, this is not gonna stand over. Okay, so you're gonna stand on this side. Can I get your name? Bernice, you're gonna stand over here. Can I get your name?
Dominic.
Dominic, cool.
Jerry.
Jerry. Charlotte. Okay, let's give them a round of applause for being brave and coming up here. Okay, so these guys have, luckily out there at Phoenix Urban Indian Hospital has some stress balls, okay? So we've got to thank them when you guys are walking out, stop by and sign your name. So what we're going to have here is, you're going to hold on to that, Bert. You and Bernice are going to hold on to that. And then you guys are going to stand over here. I don't know, are you guys okay with catching those?
Yeah.
Okay, so you're able to? All right, so Bernice and Bert, what you guys are gonna do is you're gonna throw these stress balls across over to those two individuals. Okay, you can do them slowly and you can start now, you can just step back for a bit. Okay, so what's happening is the brain receptors is sending messages of pain to your body, right? Or your body is sending pain messages to your brain. So this part is the brain receptor and this is the body. So that's what's happening right here in that illustration, okay? So what happens when we introduce opioids? Okay, let's go ahead and turn those back over. Okay, so now, and I'm not trying to make you the bad guy, but this here, Dominic, is going to play the role of being an opioid. Okay, so he's going to step in and he's going to block what they're throwing. So go ahead, or you can catch him.
I don't know, I was like,
He's like, we're going to make this line, you know. Okay, so there you go. That is what's going on in the brain. Okay, opioids is holding on to these messages of pain, all right? And the same thing can happen through all multiple drugs, and can also, what it's doing is it's telling the brain that you're doing okay, you're doing fine, and it's going to send mixed messages, right? It's going to send mixed messages of you're doing okay, you're doing fine, while in reality, you're still hurting. Okay? So, do you know what other drug works this way? Something that's legal and something that most of us take almost every day. Not Tylenol. Something that's out there. People make lots of money legally with it. What do you think, guys? I'll give it a prize if somebody can guess it. Coffee. Caffeine. That's how caffeine works. Exactly like a drug. Okay, so thank you guys for coming up here. So that is how drugs work. So that's how opioids work, and it floods dopamine. So it gives the wrong message of feeling good, feeling euphoric. And so opioids and opiates have been around since what? Since when?
Shoot, for a very long time.
Very long time?
Like back in the 50s.
50s, so you said 1950s, 1960s, who else?
Even in 1930s.
Anybody else?
yeah, it's been around.
Yeah,
1930s?
it's been longer.
Okay. Where was the original opiate coming from? The opium plant, and how long has that plant been around? Since the dinosaurs, right? We've had these mind-altering plants around since the beginning of time. What's the difference? Why is it killing people today? It's being abused, it's being misused, right? And did they cover this in the auditorium? What did they talk about in the auditorium? I was just in there because, like I said, it was getting too hot for me. What did they talk about in there? Give me something.
Drug trafficking and how the
Drug trafficking?
the illegal drugs.
Yeah. So let's go ahead and go to the next slide. So opioid plant has been around a long time. Different types of plants that cause the mind to alter have been around for a long time. And it's because us human beings, we're the ones that teach or say how we're going to use it, right? And that can go for anybody, right? Human being, we choose how we're going to use that plant, how we're going to manipulate it, how we're going to use it, if it's for pain management, if it's going to make us feel good. You know, alcohol is regulated like that, right? Alcohol is fermented, whatever, grapes, oats, potatoes, that stuff that has gone bad, but we ingest it, making us feel good, right? So I'm here to tell you, so go she, zayat and she, what on the So along that practice, that goes along with trauma, what we experience as human beings. We're struggling through the human condition. That's what we're constantly fighting, right? What makes us feel mad? What makes us feel sad? What makes us feel confused? All those feelings, that's what comes with being a human person, right? Am I right? All that comes with us. So it's our job, prevention specialists, to go out and tell young people and everybody else, because everybody I see here, I know we have the age word of elders and adults for this session. I sort of disagree with that. Everybody I see here, I just see them as bigger kids, right? That's just how I feel. Do you guys feel like you're bigger kids? Right? I feel like everybody in here is still 12, 13, 14, right? You guys feel like that? See, elderlies, they don't tell us that. That's one thing I found out, being on this planet for a while, is that we're all bigger kids, right? So what they're talking about over there is almost the same thing. When they say we're talking to youth, I feel like we're still youth. All of us are still youth. Because knowledge is something we're not going to fully grasp in our lifetime. We're always going to be learning. And such it, we're going to be learning. So when we talk to kids, we talk to adults, we talk to them the same way. And of course we have this prescription of opioids. We have 2017, so I apologize for this. You can't really see it, but it says 2017, we have 17,000 deaths from prescription opioids. 2020, we have 16,000 reported, and then 2021, we have also 16,000. And then next thing over is we have fentanyl-laced stimulants. 2010, 235 deaths. 2021, 34,000 deaths. Substances, stimulants include methamphetamine, cocaine, and other drugs. So this opioid plant that has been around for thousands and thousands of years on this planet is now it's been synthesized since the 1950s, right? And morphine is named after the Greek god Morpheus, the god of what? Dreams, right? Yeah. So Morpheus is the god of dreams. Morphine, so that's an opioid. So during that time, it's now being synthesized and it's being made illegally, right, Bert? So what we mean is this natural opioid plant, its chemical formula is now being made synthetically. It's made synthetically, it has a medical name of fentanyl, and it's used for pain management. And it's heavily used, in the hospitals when somebody's had a surgery or someone's going through something in their hard time of life. I really don't like that when the doctors start giving their family members fentanyl, especially if they're like in the late stages of their life. And they're like, we're going to increase their fentanyl. We're going to increase this. We're going to increase it. I'm like, hold up, let's be with our loved ones for a little bit longer. Keep them lucid, keep them talking to each other. I really don't like that when doctors start doing that. So it's fentanyl that's legal. It's used in the medical facilities by doctors. And then later on, fentanyl in all drugs, alcohol, smokes, cigarettes, everything is looked upon as something to make money, right? Peso, delante. So that consumers, that's what we're looked at. People that make these drugs legally and illegally were consumers. Down to, sorry, but I'm not going to open it up. Down to these, right? We're consumers. We buy things. We buy laptops, we buy computers, we buy clothes. We're all consumers. And that's how people look at us. That's how people that make the illegal drugs, that's how they look at all of us. We're looked at as consumers. So they start making it cheaply and more illegally, and they push it, they push it, they push it. So this illegal made fentanyl, synthetically made fentanyl, is being pushed into the United States. And now that so much that it takes a microgram to kill one person. I attended a drug identification class with Bert about how many weeks ago? Almost a month ago. And it was just horrifying to see the presentation of what the DEA, former DEA agent, told us about all the different synthetic opioids that are out there. So the more we try to do prevention, the more the drug dealers thinking, hey, how can we make more money? How can we make more money? How can we get these kids to buy opioids? How can we make them use? So what do? They add colors, they give it different funny street names, and all these things just to promote the drug. It's not really doing good business for them because people are dying. One of my, how do you say it? One of my cousins, and they found out that later he took a pill and he didn't wake back up. So when this drug is out there, it's killing people. It's taking lives. And the only, last year was the first time we had the first annual Opioid Summit. And this is our second year. So the more we have these discussions, the more we talk about it, the more you can be prevention specialists, right? You guys are out there, you guys provide this information. That these opioids and these synthetics are killing our people. They're killing everybody that touches. So, next slide, and then I'll let you take it away from there. So, Bert's going to talk about safe medication storage.
Okay, thank you, Delton. Delton is, I teamed up with Delton 2 years ago, and since then he got me into prevention work. My background is social work and probation, and this is my first run with mental health, and it's pretty fun. It's less stressful than social work and probation work. But so next we're going to talk about safe medication storage. So we have what the image in the photo. So our program has ordered so many of these, and this is one thing that we do distribute out into the to our community members and the public. And it is a safe medication, or it's a medication storage. It has a lock. So this is an item that we go out, when we go out to communities, we share with our community members. And so a lot of them are very happy to receive them because, you know, I think we know, because my grandma used to have medications and medications and medications. And sometimes she would mix her medications because she was like, okay, well, I'll have one huge bottle and I'll put all my medications in there, and I know which one to take in the morning, which one to take at noon, which one to take in the evening. She knew, I didn't know. But so this is what we have, and that's what we're going to talk about. It's used to store medication. We have, this one is not too big, but if you go to a Walmart or some of the other stores, they do have a bigger size. I have one that's actually bigger, but you'll find them on Amazon for $16, $20, also at Walmart. So they do have a lock, and it's so that we could keep our medication safe, whether it's Tylenol or prescription opioids or even cough medicine. So the one that I have at home is actually it has a deep compartment, so I'm able to store cough medication in there. So what we tell people when we go out to chapter houses, when we talk to the elderly population, because usually it's that population that has medication for pain management. So we let them know that not to store, or we don't recommend storing your medication in the bathroom, because who has access to the bathroom?
Everybody.
Everybody, from babies to toddlers to our relatives that come visit, and then anyone that might be staying the night to visit. Everyone has access, and And of course, if you have a relative or a family member that might be misusing opioids, they're going to have access to any opioids, and they're going to take and then we encourage them to keep their medication stored in a container elsewhere other than the bathroom or the kitchen cabinet, because that's the common places where people store their medication. And of course, we tell them not to share the medication. And this, I will go back to my grandmother, my late grandmother. We would go to a chapter house when I was younger, and I would go with her to Kenji chapter house, and maybe another relative will come up and say, "Oh, and then they would sit down and they would talk. And then maybe the grandma will say, my grandma would take out her medication bottle and she'd be distributing medication in the chapter house. So we encourage, anyone that has any prescription or not to share, even Tylenol, you don't know what is in medication these days, especially if they're not in its original container. So, and this we also share with our youth when we go out and do outreach work. We encourage them not to share any medication or receive any medication from anyone that's offering what they might say is oxys or Xanax. It might not be oxys or Xanax. So, and then of course, the next item is to keep the opioids in its original packaging. And I'm not certain how pharmacies work, but from my own personal experience, it's just a quick, "Hi, are you so-and-so? Well, do you know how to use your medication? Yes, no? And okay, bye, sign here, go." And that's it. And what about our grandmas? What about our grandpas that go in? Sometimes you see them go in alone, and you wonder what the transaction is behind closed doors when they're meeting with the pharmacist. So, and that's where we come in as prevention workers, and we encourage them to ask questions or go with a family member that might translate for them. And also, you have the right to ask for a translator when you go to pharmacy, and we let our population or our grandmas and our grandpas know that they can ask for a translator at any hospital visit or pharmacy. Also, one of the initiatives with our program is we do the drug take back program. We do that twice a year, one in April and then one in October. So we have one coming up in October, and I believe last year was the first drug take back initiative that we had on Navajo Nation. And we set up in Windrock. We also set up in Delton. We did one in Crown Point. So this year we want to expand, and we want to go into more locations. And I understand we can't, capture every area, but how we try to do is like areas that a lot of people will go through, and we'll get more medications returned. And of course, the local hospitals, they have the container for return medications. So such as Walgreens, and then the hospital, the pharmacies on Navajo Nation to have the container for return medication as well. And we encourage people that if you're done with your opioids and you're no longer taking them, return them. Don't share it with relatives, or don't, store it so that, someone might have access to it.
And they also encourage them not to dispose in their toiletry or in the trash can, because that happens a lot too.
Yes, that's correct. And part of the chapter house initiative, that's what we've been doing, because a lot of people don't know, they just dispose of their medication in the trash can. Go ahead.
So one of the things we follow is what the pharmacy do. So they have a best practice in the system called medication reconciliation, and it's supposed to be for every patient that they see. You look at the chart, make sure everything is up to date. It's kind of like a default system, just for that very reason of polypharmacy.
Okay, thank you. So, and of course we encourage alternative pain management. So, depending on the pain, so we understand sometimes surgery, we're not going to be able to go to physical therapy for surgery. Maybe after healing for some time, and then they'll recommend physical therapy, but for anything immediate, they are going to prescribe opioids, prescription opioids, so that's, I guess, unavoidable. Even something minor such as a tooth extraction, that you get opioids. And personally, I had my wisdom tooth removed, and they gave me opioids. And I teach about opioids and I talk about opioids, and that's my job, and that's what I do. Then I get it, and then I'm like, oh my God, what do I do with this? But I tried to avoid taking it, only because I didn't want to take it. I didn't want to deal with the side effects, which can be constipation. And I was like, okay, if I can deal with Tylenol right now, I'll take Tylenol. So we encourage, if you can find a different way of managing your pain without the opioid, but if opioid is necessary, you can't avoid the pain, then take it as prescribed, and that will be a prescription from your doctor. But in instances and maybe medical situations where you can take ibuprofen or acetaminophen, then we would probably recommend that rather than taking the opioid. Also, acupuncture. They do have acupuncture services in Gallup, I'm aware of, and in some border towns. And then on Navajo Nation, some of the facilities do offer acupuncture, and you would have to get a referral from your medical provider for that. Also, injection or nerve blocks, local or other medications to help short circuit pain. They do offer that. And a lot of these things, or all of these things, you should talk to your medical provider about your options and maybe what might work best for you. And also, some of the risk factors for opioid misuse, I believe Dr. Begay talked about ACEs, and most of us experience these things in our family as we're growing up. Sometimes we can't avoid things that happen in our family, in our childhood, but some of these risk factors include poverty and unemployment, because these are situations that are circumstances that might increase your risk of any substance use or misuse, and even including alcohol. So unemployment, family history of substance abuse, personal history of substance abuse, young age, because who in here can tell me at what age our brain is fully developed? 25, 26? It's around that age, 25, 26, that our brain is fully developed. So we share this when we give our presentations to the youth. That is why they're at risk for risky behaviors such as substance, sex, drugs, driving fast, just being, reckless, because we're not gonna, and I share this with the students when I talk to them, and, just last week, there was a young man that had a Ninja, one of those motorcycles. He was doing 90 miles an hour on 491. Are we gonna see like 70-year-old grandpa doing that? No, because we kind of know that's not safe to do, right? So, and unfortunately, the young man got into a car crash and he passed away. So things like that we share with our youth and when we talk, but also history of criminal activity or legal problems, including DUI, regular contact with high-risk people, high-risk environment. So when we talk about who is in your household, who are we hanging out with, who influences us to make some of these decisions, and then risk-taking or thrill-seeking behavior, just like I mentioned, the incident that happened last week. Also history of anxiety, severe depression, mental health disorders, stressful circumstances. We can't avoid stress, right? Every day. I was stressed this morning. Some of our presenters didn't show up, and I was stressed, and I was trying not, and then I had caffeine, and I don't have caffeine. My body doesn't tolerate caffeine, so that just doubled the stress. So, okay, well, Delton, go ahead. We only have 6 minutes left, so we'll try to get through this.
I think we'll stretch it, because I think they started off late, right? It was like past 1 before you guys showed up, right? It was like 1:15, right? Should we stretch it a little bit? But yeah, we do have 6 minutes, but we'll do our best to try and put it all. We have protective factors. I know you guys can't see it, but you guys want to play a guessing game? Like, name me 1 or 2 protective factors. Coping skills,
Developing like a spiritual guidance for yourself.
spiritual guidance. Yes, and I'll read it. Positive connections to family, friends, community, parent involvement, strong coping, problem-solving skills, meditation, exercise, healthy conversations, cultural, religious beliefs, value, self-preservation, availability of access to clinical services, medical treatment, willingness to get treatment. I think this last one is very important, right? We can paint a pretty picture on recovery, but the truth of the matter is the person's going to want to have to get help, want to help. They want to have that willingness to say, hey, I have a problem, I have an issue, I need help. But that help comes with that scary word. You know what that scary word is? You guys know what that scary word is? I think that word scares all of us in here.
Yeah.
What was that?
Fear or yeah.
Fear or yeah. That's the word, but there's another word that scares all of us. I guarantee it, it scares all of us. Toughest, strongest person will.
The fear of change.
Fear of change. Let's give a round of applause. Fear of change. That's the most scariest thing that we all experience in life. So anytime we come across those type of feelings, there's a whole list of what was we're going through. Change is the most fearful thing. Okay, like change for me was getting back into school, taking that huge step of saying, hey, I need to get my degree. I need to quit lollygagging around and get that paper. Change could be a simple routine difference, right? Like if a single parent was has to be home earlier because their kid gets out of school earlier because they're a single parent, they have nobody to watch that kid at home. That creates change, right?
Age is the same way too, getting older, grandkids getting older, your children are a lot more of adults now, yet you see them as like a 10-year-old little boy, but yet your son is like 21 years old and stuff. There is
Exactly.
a lot of change.
And I want to go off something real quick on that, and then we'll get into finding balance. So change is the very thing that scares all of us. Change of work, change of pay, change of living conditions, right? Wouldn't that put us kind of out of sorts? But the most species on this planet that's real good at adapting is who?
So,
There's only 2 species that change their environment to adapt on this planet. You guys know who those 2 species are?
lizards.
Lizards. I think she's thinking chameleon. There's only 2 species on this planet that can adapt and change. Ourselves, right?
That's
Human
what
beings.
I said ourselves. That was my first one.
Oh, okay. I didn't hear you. I'm sorry.
I'll say
I'm getting
ourselves.
older too, so. So us ourselves. So that's the first species. What's the second species on this planet that changes their environment to adapt?
Someone said birds.
Birds. That's a good guess. What's the second species that changes their environment to adapt on this planet? On this big mud ball that's hurtling through space at thousands of miles per hour. But
The
yet
sun?
somehow we're sitting here. You guys want to know the answer?
Yeah.
Okay. It is the beaver. The beaver changes
I
its
wouldn't even
environment to
think of that.
adapt its home environment. So finding balance. How do we become in balance in our lives? What was that word again? Change, right? What do I do in my own life to find balance? What's one thing you guys like to do for balance?
I had to learn to accept it. I had to learn to accept it.
Acceptance,
and then adapt
right?
into that change.
And adapt. How do substances like opioids and other medications lead to imbalance?
Anxiety, stress can lead into things that you think are happening to you, and you keep getting seen for it, and yet you're thinking you are feeling pain, or something's wrong with your heart, or you're forgetting stuff and everything.
Mhm.
You know, you can misuse the
You become dependent, and then that starts controlling your life instead of you being able to make your own choices.
Yes,
Or having
exactly.
a difficult time.
Mhm. So that's almost exactly what the definition of addiction is, right? You guys know
Yeah.
what the definition of addiction is?
A dependency on a substance that influences your actions.
Sorry, Dominic, you're wrong. Totally wrong. Addiction is a pattern of behaviors that takes you out of your usual pattern of living. If it gets in the way of your daily routines, that's an addiction. If I'm on Facebook too much and I'm not doing my job and I'm not doing prevention, this is an addiction. If I get sick and I get diabetes and I'm constantly eating, maybe I'm eating my emotions, maybe I'm going through something, but I'm eating, and too much of that food is going to make me sick. That's a form of addiction, right? Anything and everything can be an addiction. Any type of behavior that disrupts your daily routine. But good job, Dominic.
You made me the opioid.
I'll
so-
give you, yeah, I know.
Right.
I'm picking on you, Dominic. So, but no, thanks for being a good sport. So, next slide, please. Actions we can take. It's important to be aware of the solutions available to us, effective tools, families, healthcare professionals, educators, prevention, screening, intervention, right? Intervention is pretty hard to do. Overdose prevention. Effective treatment and continuum of care and traditional practitioners. That's specifically stating Navajo area region. And of course, this doesn't have to do with Navajo area region. This can go across all nationality, all tribes, whatever your belief system is, we encourage it. Us in DBHS, we do not talk against any religion. We do not talk against any nationality. We do believe that having faith, having that foundation of faith, whatever you choose that keeps you away from opioids and alcohol and making positive changes in your life, that's what we root for. So if you're a traditional Navajo, if you're a traditional Native American, and you choose to use traditional methods to stay clean and sober, do it. If you're a Navajo that believes in faith-based, the Bible, and that keeps you clean and makes positive decisions for you, do it. If you believe in Buddhism, keeps you clean, makes you make positive decisions, do it. Right? So A with Al, that's what we promote here at DBHS as far as being opioid free, and I hope that we educated you some way, somehow today. I hope that we did. I hope you took something from today's presentation. If you did, you guys can clap your hands. And I know this is the end of our presentation. Give us excellent marks on our surveys. Say Delton and Bert did the best presentation on opioids. Say they were an awesome group. But
Bert,
thank
can
you
you
for
go
listening. Thank you for listening. Thank you for being engageful
One more.
and being
That way.
interactive with us.
Other way.
Because that's just the way I present. I feel like that's the best way that people learn, is to engage and be interactive, move. Movement is a strong tool. Some of us are video and audio learners. Some of us have to move to learn. So yeah, it's thank you for being here. And again, thanks for attending and continuing being bigger kids.
Thank you.